Welcome to the ASAD webinar for this quarter. And it's a great pleasure to have Professor Eve Hogervorst speaking to us today about a very, very important topic about Alzheimer's and gender, how it plays out across the lifespan. And it's a great pleasure also to have Professor Linda Lam chair this webinar. Professor Linda Lam is Professor of Psychiatry at the Chinese University of Hong Kong. She's also the Secretary General of the Asian Society Against Dementia. We do these webinars every quarter, not just for members, but anyone who's interested in the field of dementia. And the effort, of course, is to raise awareness. My name is Krish, and I tend to host these events. So welcome to everyone, and welcome to our speaker and chairperson. Handing over now to Priscilla Lam to introduce the speaker and the topic.
Thank you, Krish. Thank you, everybody. And today we have the great honor to introduce to you Professor Eve Hogervorst. She is the professor of biological psychology at Loughborough University, the top 10 university in the United Kingdom, and if I remember correctly, is the top 1 university in sports science in the world. And she has studied women menopause and dementia risk since 1988. And Eve researched this as a researcher at Oxford and Cambridge and worked with many well-renowned experts in the United States as well. She is now the expert member of the committee to devise the NICE guideline on hormone replacement for dementia, and she has written over 200 peer-reviewed publications, including many book chapters. And without further ado, let's ask Eve to deliver her talk on the topic of dementia and gender in a lifespan story. Eve, please.
Thank you very much, Linda, and thank you so much, Krish, for inviting me. I've known Krish for a very long time, and it's such a pleasure to be able to speak to this forum. As a disclosure, I'd like to say my apologies for the strange split screen. I hope it's not an issue in accessing it, but yesterday I gave a talk on technology and dementia, and somebody fiddled with the computer, so unfortunately my ability to reverse his technology is not great, so my apologies for that. I'd like to disclose that I acted as an expert for the NICE committee in the UK and for ESRI in the EU on dementia and women and the use of HRT. But the opinions in this talk, while they may reflect sometimes those of NICE and ESRI, are my own. So that was my disclosure. When we speak about women and dementia, we need to know, and most cohorts will show that women have a higher risk of Alzheimer's disease, the most common form of dementia. And after the menopause, we can see that women have lower levels of estrogens, and estrogens, and particularly estradiol, can protect the aging brain against dementia and memory loss, and I'll illustrate that in this talk. Now, this slide shows how older women have a high risk of Alzheimer's disease, even if we look at age-related incidence of dementia. And we can see that starts to occur after the age of 18. Now, many studies have found this, but the question is whether this is a form of survivor bias. Now, for women, dementia is the leading cause of death, and this has been the case since 2011. Now, if we look at causes of dementia, of mortality in the UK, we can see that for women, this is dementia, but for men, it's ischemic heart disease. So if we look at this in a little bit more detail, and I used ONS data from the UK to look at age at mortality and causes of mortality. And what we can see here is that women tend to die of dementia at a much older age, and this is by far the largest group here. However, men tend to die much earlier of cardiovascular diseases, in particular ischemic heart disease. And because the two share risk factors, it may be that this explains the gender difference. Now, we know that in midlife, obesity, high blood pressure, high cholesterol, diabetes, anything that's bad for the heart is bad for the brain. And I coined this phrase at an Alzheimer's Research UK meeting many years ago. But there are things we can change about that risk, which include exercise, diet, and smoking, but also sleep. Now, there are things, however, we can't change that mitigate that risk, and that is an older age.
Eve, I'm sorry,
Sorry?
I think your
Yeah.
slides are not moving.
Oh no. Oh no. Oh, that's really
We've not
bad.
seen your
So
next
they're
slide.
Yeah.
moving on my. Can
Oh,
you
yeah.
Yes.
see this?
You've
Yeah,
gone
now
down to
it's
7 now. Yes, yeah.
Okay. Oh dear. This is what you get when you let other people run your computer. Can you see the slide? So this was
Yes,
my slide on heart disease.
you're on slide 6 now. Yes,
Yeah.
thank you.
Right. Thank you so much for letting me know. So if we look at these risk factors for heart disease, what we see is that, for instance, data by Skoke showed that high blood pressure in midlife was a risk factor for Alzheimer's disease. But 1 to 2 years before the onset of Alzheimer's, this seemed to change. And now, people with Alzheimer's disease, for instance, in Oxford, when we looked at this, people with Alzheimer's disease actually had lower levels of blood pressure than controls. And we can see the same for cholesterol, and we can see the same of loss of body weight. These are and high BMI is a risk factor for dementia in midlife, but no longer just before the onset of dementia. And the question is whether we see this modification by risk factors over age be a factor in Alzheimer's disease. Now, when we look at heart disease and dementia risk, we see that in the menopause, these particular heart disease risk factors start to change. So a lot of women gain a bit of weight, especially around the waist. Their cholesterol tends to get up, especially LDL cholesterol. Um, many women become pre-diabetic, and we can see the blood pressures rising. We can see the amount of fat around the heart increasing. And what's really interesting is that the women who report the most severe hot flushes also have an increased risk for heart disease and stroke. And now, according to some studies, also for dementia. So there seems to be a relationship between that increased risk of heart disease, which tends to be more severe after the menopause, and which may set women up for a later risk of Alzheimer's disease. However, men also have this risk of heart disease because of different lifestyles in the past. So men tend to be more likely to smoke, to drink, and perhaps to go to the doctors less. So they tended to die of heart disease in the UK at an earlier age. Now, another factor that could play an important direct role is sex steroids. And these are data from Oxford where we can see that estrogen levels after the menopause are much lower in women than in men, except when they use HRT, hormone replacement therapy. Now, what's often overlooked in women is that testosterone levels also are very low after the menopause. And testosterone is very important because it can be converted into estradiol in fat tissue. And so testosterone, 1 nanomole of testosterone, can be converted into 1,000 picomoles of estradiol. And so that even these small differences in levels can make a huge impact. Now, here we see, this is a cartoon I made a long time ago, where we can see all the many potential benefits estrogens and also testosterone, which has its own receptors, can have in the brain. And here in particular, estrogens can stimulate the cerebral blood flow by causing vasodilation. It can improve glucose uptake in the cells, stimulate the branching of dendrites to its co-localization with growth factors, we can see that it can act as an antioxidant. It can reduce the toxicity of beta amyloid we can find in Alzheimer's disease brains. And in fact, in general, many of the factors, including inflammatory factors or glutamate toxicity, we think play a large role in age-related memory decline and dementia. Now, if we look at how these levels decrease, we can see that in natural menopause, we see a sort of gradual decrease over time, and we don't see that much of a dip in testosterone. A little bit goes down. But here in the surgical menopause, when the ovaries are taken out, we can see a sudden drastic drop in estradiol and also in testosterone. So we would imagine that considering the effects, the many effects studies have shown, basic sciences studies have shown, animal research has shown, into estradiol's beneficial protective effects on brain function, that it should, going through menopause, should have a massive effect on the brain. And a couple of years ago, I was commissioned to write this paper on cognition and mental health in menopause. And what we found there was that there weren't actually very many large differences overall in women going through the menopause. And in the transition and the early stages of the menopause, we do see some changes. We see some changes in implicit learning and how to do tasks. We see some changes on average in speed of information processing on some tasks. But overall, they seem to be quite small. The important fact, though, is that when we reviewed this for NICE and for and not so much for Esri, but for NICE, looking at the natural menopause, we found that hormone replacement therapy didn't protect against any of this decline. It would act on brain function for a couple of months, but it didn't seem to have an acute effect for longer than that. So any benefits we saw in women with severe vasomotor symptoms were reduced after a year. And there have been some large trials, ELITE and KEEPS in the US, looking at early versus late menopause and whether HRT could affect that. Different forms of HRT could protect cognitive function, and they didn't show any effects. Now, natural menopause, and we can see here, these are data from Petra Tyler's looking at the transition longitudinally. And what we see here is quite interesting. So she split these data for women with a high BMI, and as I told you, testosterone can be converted in estradiol into fat tissue. And what we see in these women with a high BMI is that before the menopause, they score a little bit lower, but then afterwards, their performance on verbal memory, which seems particularly sensitive to this menopausal transition, seems to be maintained. Whereas in women with a normal BMI, they don't benefit from repeated exposure. But we can see that overall, the change in scores is not that big. Now, we looked at this, we did a systematic review, and when we follow the same women over time, longitudinally, we see overall small temporary changes in verbal memory and learning, but they don't seem to persist, and possibly some negative effects on speed of performance on some tasks. But we don't see that in all women. And also, when we compare women premenopausally to those postmenopausally, we don't see any effect on verbal memory or any of the other tasks. So this is interesting. Pauline Markey and Weber did some research in this, and what they found is that the dip around the perimenopause and just after the menopause is likely to reverse. So they followed these women longitudinally, cross-sectionally here. They showed, they followed the women longitudinally here. And this data, and that's really interesting, is cross-sectional. And then these women were followed longitudinally to see if that persisted. And in that data, a quarter of the women, only a quarter of the women, showed worse verbal memory during that transition. And that was related to worse sleep. Now, a lot of these women also showed no change or even better memory and better attention. So it's very important from a clinical perspective that you don't automatically assume that all women are going to have cognitive issues going through the menopause. And the other message is, and this is really important, is that while we see that some women aren't learning so well, have some small problems in verbal memory and some planning and speed of information tests, we see that this reverses in the majority of women. And anecdotally, I had very severe perimenopausal um, name recall issues. So all of a sudden I just couldn't remember people's names. And I spoke to Professor Amy Spector at UCL, who said she had exactly the same issues. And she wrote a very important article about this in newspapers. And I think it is very shocking, obviously, as an academic, because name recall is one of the most important things you have as an academic. So this was very shocking. However, for both of us, this reversed a couple of years after the menopause. And importantly, hormone replacement therapy did nothing to mitigate it. So, what is this related to? Well, it could be because of the hot flushes, especially in women who suffer from high stress. And of course, women in midlife usually reach the plateau of their career. They can have a lot of stress, and that can affect their sleep. And this together seems to result possibly in worse function in some women, but not in all. And another thing that's very important clinically is that women without a history of a clinical depression usually don't develop depression de novo. Um, Now, what we found, MJ Cook and myself did analysis in a cohort of almost 300 women at different stages of the menopausal transition. And what we can see here is that the worst symptoms of anxiety, of overall poor psychosocial quality of life, depression as well, were worse in the perimenopause. But in women who had reached the postmenopausal state, that seemed to have reversed. And indeed, there are several other studies using the right instruments following women over time, which showed a perimenopausal depression. So the question is here, do we see a rebalancing in brain function after these perimenopausal hormonal fluctuations in women undergoing natural menopause around the age of 50? So if women report depression, it's important to see what is underlying. Is this caused by poor sleep? Is it caused by stress? What can we do to reduce this? Now, MJ was very interested in mindfulness. This is MJ who did her PhD in this. And in this cohort, surprisingly, mindfulness, the women who engaged in mindfulness had worse mental health. So we can see that here compared to the other women. However, women who did yoga had better mental health. And this may be because if you start focusing, so there's different forms of mindfulness. If we go out for a walk and we experience nature and all the wonderful things around us, we externalize our attention. That might be beneficial. But if we try to do mindfulness focusing on our bodies, maybe anxiety and other symptoms actually get worse. And there are some indications of that. However, things like yoga can definitely benefit menopause, but not all symptoms. So we can see that menopausal symptoms improve, but not necessarily the hot flushes, and also not necessarily the memory, but definitely mood, anxiety, depression. Overall, this wonderful meta-analysis by Wang was shown to be reduced in women who do yoga. Now, we used for our experiments, we used yoga, a yoga stretch as a control. And over 6 to 12 weeks, we saw that women, menopausal women who were doing strength exercises, actually improved in their memory performance. And this is the verbal fluency test. We can see that that improved after 12 weeks. And this is an episodic verbal memory test. As we can see in the women who did yoga stretch, there was not much of an improvement. So not a direct effect on cognition, but it could be an indirect effect through improved sleep and improved mood. But the flushes themselves are not necessarily effective. Now, exercise in general, we know, can improve cognitive function and reduce the risk for dementia by acting on the metabolic syndrome risk factors, stimulating cerebral blood flow, regulating blood glucose, and promoting dendritic outgrowth of neurons. And a lot of studies have shown the benefits of physical activity, in particular, something like walking. If you combine that with mindfulness, is trying to reduce your stress, focusing on the external environment, seems to be so beneficial. And also, just the effects of walking briskly is very beneficial. This data, this UK Biobank data, over a 7-year follow up, showed that dementia risk was reduced by almost half in that magical number of 10,000 steps. But importantly, the benefit was already seen in engaging in just a level above sedentary, 3,800 steps. And very important for a menopausal group is that the menopausal symptoms and mood benefits were also shown to be improved by walking, and also flushes were reduced by 50%, and people were reporting better sleeping. And these factors are so important for cognitive function. So walking is a good idea. Mindfulness, we are not so sure about. Resistance exercise is a good idea. But what about hormone replacement therapy? So let's talk about this for a bit, because it's been in the news a lot over the last couple of years. And hormone replacement therapy normally consists of an estrogen. And then for women with an intact womb, we add a progesterone to protect against endometrial hyperplasia, or cancer of the womb. It's a precursor for cancer of the womb. And what we found in our cohort was that the women who currently used menopausal hormone therapy, or had done it in the past, had worse mental health, including more memory complaints than the women who did not use HRT. Now, this might be different for women. And when I reviewed for ESRI on early menopause, usually induced by surgical menopause, sometimes it can be iatrogenic, so we don't know what the reason is. But early menopause, according to the data by Walter Rocker, can increase later life cognitive impairment. And the earlier the age at this induced menopause, the higher that risk is. Now, Walter Rocker is a big proponent of giving these women add-back hormones. So what about this group? Now, one of the papers that set off this interest, and mind, this data had been investigated prior in the 50s and 70s, but what really set this off was this paper by Barbara Sherwin, who found that in women who underwent surgical menopause before the natural age of menopause, there was a sharp decrease in, again, verbal memory, which seems to be so very sensitive and which can be an indicator of later life dementia risk. Now, if these women were given either estradiol or testosterone bolus injections, that didn't occur. And in fact, these women reversed back to baseline of controls who had not undergone surgical menopause. Then, if they were given placebo, they went down for 2 to 3 months. And then if they were given the treatment again, they went up. So a very elegant crossover study. Now, many people have shown that women who undergo surgical menopause have an increased risk for dementia, and the women who take hormones then do not. But this study only showed this for 2 to 3 months. Now, we looked at highly symptomatic women, including women who'd undergone surgical menopause. And what we saw was that that benefit tended to plateau and then reverse. Now, previously, when I first started reviewing this data in 2000, we saw that earlier there had been no effects. So these studies are listed um, in when they were published. And what we can see here is that earlier there was no benefit of taking HRT. However, then, after Barbara Sherwin published her results, all these studies all of a sudden started finding a halved risk for Alzheimer's disease. So at the time, everybody was really enthusiastic before the turn of the century. Everybody's really enthusiastic, including myself. And, many people said, spurred on by Sherwin and Victor Henderson, whom I worked with in the US, also had a very seminal role in this. HRT can protect against cognitive decline and dementia. But then after the turn of the century, some of the same people, including myself, said, well, it's very clear HRT does not delay or treat cognitive decline. And when I got my job in Cambridge, I was driving to work one day. I heard Professor David Purdy say this, and I think it was very indicative of the time. So something seminal had happened. And what was that? That was this, the Women's Health Initiative study. So because of the enthusiasm generated by the observational data and some of these small short-term trials, we saw that we and others said, we have to start doing this in older women to see if it reduces the risk for dementia. If we can do a trial that reduces the risk for dementia. And what this trial showed was that women who took over the age of 65, who took a combination of an estrogen and medroxyprogesterone acetate, these women had an increased risk. And overnight, women stopped taking HRT. And we were called to Wyatt, who produced Premarin, which had been under investigation, to explain these results. And we were baffled. However, when you look at the data, there's only a 1% difference between the people who took placebo and people who took the active treatment, but it was still there. And so as a result, people started talking about the window of time hypothesis. So people said, well, if you take HRT before the natural age of menopause, especially if you have undergone menopause at an early age, your risk is reduced. But if you take it after, especially if you're in your 60s, that risk is increased. Now, I thought, because I'd done that study over 12 months in highly symptomatic women, and what we saw was that up to 3 months, there was an improvement, it plateaued, and then after 6 months, people did reverse back to baseline. And this had been shown earlier in the 50s in women with dementia, where we saw an initial benefit of estradiol, and then that reversed. Also, unfortunately, in women who had undergone surgical menopause at an early age, after about 10 to 16 years, women who had undergone surgical menopause and were given estradiol or other forms of HRT had worse cognition over time. And when I went to Oxford to test estradiol levels in women and men with Alzheimer's disease, in women we found that high estradiol was related to having Alzheimer's disease, and at the time also other people were finding women with high estradiol in Alzheimer's disease didn't have better cognition, they had worse memory, they had smaller hippocampi, and using good assays, many other studies found that levels of estradiol were not lower. In fact, they were, if anything, higher in women with Alzheimer's disease. So at the time, we were a little bit baffled, and then Robbie Brinton Diaz came up with a healthy cell bias. The healthy cell bias says that if a neuron is healthy, estradiol can help maintain that neuron. up to a certain point. But then if damage does start to occur to the mitochondria or the calcium channels, estrogens will make that worse. They start accelerating that. So that could explain why in over time, with a longer duration in the older women, we find negative effects. Now, that doesn't explain some of the observational studies, though. But there are two huge forms of bias. And one of these biases is recall bias. So, by the very nature of dementia, women with Alzheimer's disease are less likely, 20% of these women doesn't recall that they ever used HRT if you ask them retrospectively. So this is data that was much ignored at the time by Petit in 2002, showing that if you compare recall with pharmacy data, 20% of women with Alzheimer's disease don't recall their use. However, that is also the case for controls, but that's only seen in 10%. So that might explain that doubled, the halved risk of dementia in controls who took HRT, simply because the women didn't recall it when they had Alzheimer's disease. But another very important piece of work, which was also ignored at the time in the mid-90s, is, and this is really beautiful data by Matthews of the US, where they followed women up over 8 years. And what they found was that 8 years before women took HRT, they were already much healthier. First of all, they had much better education. They were more likely to have higher education overall. You can see that here. They were also already likely to have higher levels of the good cholesterol. They were much more active. They were much more likely to have lower blood pressures and had average lower systolic blood pressures. They had lower weights and they had better fasting insulin. So they were much less likely to be at risk for diabetes and dementia. So this is really important. We can see that taking HRT in the observational data was likely to be a reflection of choice of women who were healthy at the time and decided to take HRT because all of a sudden it was in the news that it could protect the brain. Now, we then decided, we were commissioned by George Perry to do a meta-analysis because these observational data are so biased by selection bias. So we see that over the lifespan, women who are better off, who are better educated, make particular choices, but they also make choices like things to join observational studies, to join randomized controlled trials. And they're more likely to be healthy. So what we try to mitigate that is to look at countries where there were national GP registry data. And we found 7 studies, 2 from the East and a couple from Scandinavian countries and 1 from the UK. Now, the only study, and 1 from the US. Now, the only study that showed benefits of HRT was from the US. And that was from Robbie Brinton's group, who showed that there was a reduced risk. Now, that data did not control for education. It was from a national health insurance database. Now, in the US, and the same is the case here for the Southeast Asian cohorts, they were also from national registry data. But the difference being that in the US, having health insurance is really for the privileged because it's incredibly expensive. In these 2 databases, where there was an increased risk with use, everybody was covered by this national health insurance. So that is an important difference. And these studies also controlled for education. So this data, this is the only national US registry which showed a reduced risk. These other studies, the Scandinavian, the UK ones, and the East Asian ones, all showed that with an increasing duration of combination use, there was an increased risk of dementia. And this is one of these from Finland, where we can see that with longer duration of use, in this also both estradiol and the combination HRT gave an increased risk. This is a huge study by Vinogradova from Nottingham in the UK using GP registry data, showing that with prolonged use after 5 to 10 years of combination therapy, there was an increased risk, a slight reduced risk here for estrogen, but that might be in surgical menopausal women who tend to not take it for very long. We don't know. That needs to be further investigated because they didn't look at age of onset. That's still an outstanding question. But here, if we look at women going through the natural menopause who need to take a progesterone, we see an increased risk over time. And that could be explained by the healthy cell bias theory from Robbie Brinton Diaz. And here we see that for conjugated equine estrogen, there's not that much of a difference in risk. But here for estradiol, if we split this in terms of preparations, that risk might be lower. And important to know is that in the study showing the increased risk of dementia, the Women's Health Initiative data, that study used conjugated equine estrogen. Now here we see that the type of progesterone might play a role as well. So some of the progestrogens, like the one that was used in the WHI, medroxyprogesterone acetate, that really is more likely to increase risk for dementia with an increased time of use. So this is the meta-analysis for estradiol overall, regardless of age at onset, so whether they were before the age of 60 or after the age of 60, and duration of use didn't overall make a difference. But it might be different for women who couldn't analyze that, who have their menopause surgically before the natural age of menopause. Now, the problem with that group is that women who tend to undergo surgical menopause are also more likely to have lower socioeconomic status, a lifelong exposure to deprivation. They're more likely to be obese and to smoke. And these, of course, are very important risk factors for dementia. So that could indicate why there isn't really a difference here. We don't know. That really remains to be further investigated. But the largest group, of course, is those women who undergo natural menopause. And here we can see with the meta-analysis that overall, with increasing duration of use over 5 and certainly over 10 years, we see an increased risk in women before the age of 60. And we see that also here in the early years. This data is, we can see there's big confidence intervals. So we can't see that at a later age, but older women usually stop using HRT. And certainly after the Women's Health Initiative data, women were prescriptions were actively stopped in most women through the GP. Now, this data from Denmark were really interesting. So they showed an increased risk for use, again, like the other studies, with a longer duration of use. But they only showed that increased risk of dementia when data were prescribed before the publications of the WHI, and not when they prescribed later. Now, later means that these women might not have been old enough. They might have not had the power. But it could also be because, as I told you, there was a healthy belief bias. So people before the Women's Health Initiative data came out, including myself, very much believed that HRT could protect against dementia, could protect against heart disease. So it might have been that women were actively prescribed HRT to reduce this risk. And this data from Vinogradova shows that in the years before 2003, these older women who would have been more at risk were more likely to show to use HRT. And then that dropped severely after the publication of WHI. So it's a very confusing picture. And I've tried to make these rather crummy looking graphs to sort of indicate my line of thinking. And I'd be really delighted to hear your thoughts around this. So if we look at healthy women, as we saw by Matthews, a lot of women who choose to take HRT, including now again, are well educated. They're already at reduced risk for HRT. So before the menopause, they're likely to maybe show a little bit of a dip in 1 of 5 women. And so women start taking HRT, but the risk of dementia was very low anyway because they lead healthier lifestyles overall. Now, the reverse is the case for women undergoing early menopause, including surgical menopause. They're more likely to have a lifetime of deprivation, including obesity and smoking. So these women will show an earlier decline, and they'll also have an earlier issue with mitochondrial damage, damage to the calcium channels. And especially if they keep on taking that, that risk might increase. And that certainly is the case for women over 60, over 65, where they are more likely to have issues with their mitochondria, with the calcium channels. And HRT will then exacerbate this. And this explains the Women's Health Initiative data. Now, the question is, there are two outstanding questions. One is there indeed this effect? Or is that caused by the healthy belief bias in the 90s, where people thought that HRT would protect against cardiovascular disease and dementia, so women at risk were given this, and we see that reflected in the National Registry data with an increased risk. So estrogen didn't work, or did it actually accelerate the decline? So is this the case? The other question that remains to be answered is this one. So women who undergo early menopause, the new guidelines of ESRI came out with Walter Rucker, who said, yes, we absolutely need to give HRT. But I showed you some data from the US, from Sandra File, and also from the UK by Sandra Files, also from the US, showing that with increased use over time, or with increasing duration of use over time, we can see reduced cognitive function. So Robbie Brinton Diaz's healthy cell bias theory may hold. So in sum, overall, we don't see, when women go through menopause, necessarily a drop in objective cognitive function or worsening of mental health. In fact, we see that in the perimenopause. So perhaps the brain adjusts in the majority of women. If we see cognitive issues, we see it in 1/4 of the women, and that may be related to worse sleep or worse flushes, which are very distracting. The question is whether HRT for those women might work, but studies don't suggest it. And in fact, if there is a benefit, we can see it only for a couple of months and then it seems to taper off, and in fact might even worsen after 5 to 10 years. And this is particularly seen in older women and women who took combination treatment, and not just the conjugated equine estrogen, because Sandra File also showed it with estradiol by itself. So a longer duration treatment could do that. We didn't see it in the meta-analysis, but there is a possibility that that was the case. Or are we seeing that in our meta-analysis because of the unhealthy prescription bias, where women who were at risk were prescribed HRT? Now, estrogen alone either has no benefits, could be protective, but some studies have found increased risk. But again, this is something we really need to investigate. But importantly, and this is where the lifelong exposure comes in, is if women who undergo premature menopause and undergo early surgical menopause have a lifetime of deprivation, we really need a lifelong approach. So here we can see, for instance, that women who have better education are more likely during pregnancy to engage in exercise, which we know affects fetal birth weight. They engage in better diets, including omega-3. They live in nicer environments. So we've done some work in Indonesia looking at the slums and the effects on stunted birth weight, on stunted growth and low birth weight. here in midlife, we can see that people who have poor lifestyles before they go to menopause, or the reverse, good lifestyles, have a different pattern of aging and dementia risk. And so, from a very early age, we can affect that trajectory, and we should, which is why now in Indonesia, we're focusing, for instance, more on prenatal care to try to stem the increased risk. In Indonesia, it's huge, according to some data that were published a couple of years ago. So I'd like to acknowledge my opportunities to work with the experts in Esri and NICE, and I said where the findings are similar, the interpretation might be slightly different. So this is my own work, my own interpretation from my reviews. I'd like to thank all the people I worked with in Oxford and Cambridge and in Indonesia, people who helped me do some of the essays, and of course the people who funded us, and the public, and you for listening. And again, my apologies for the slides. If there are any questions, I'd love to answer them.
Thank you very much. Thank you, Yi, for your wonderful talk. We have two questions posed. The first one is hot flushes are autonomic phenomenon, and
Yes.
fogging. Fogging is also associated with dysautonomia. So do you think that perimenopausal causes autonomic dysfunction, and that is the reason for the transient change in the memory performance?
What a brilliant question. And thank you so much, because this is something I really have been thinking about recently, trying to look at that vascular reactivity. What is it about the women who have worse flushes? Now, some of these women are more, are obese or overweight, and the weight traps, the heat in and insulates. So that could be one of the reasons, could be mediated, but not necessarily, because I'm not overweight and I had the worst flushes and the worst memory issues. So the question is, what is that relationship? Is that indeed autonomic dysregulation? Thank you. And I think this is something we really need to look at. We did some work with the hot flushes previously, and they're an interesting phenomenon, because the worse you feel about them, the more stressed you get, the worse the flushes. And so there's definitely something there with that regulation going shipshape. And partly that might be mediated by norepinephrine or noradrenaline. And so this is a really interesting topic, which we need to investigate further, which might also be why in some of the studies, SSRIs, for instance, used had benefits. Or, for instance, those treatments acting on all monoamines, for instance. Yeah.
Yeah.
Great.
So do you think that, yes. Do you think that the timing of HRT would be crucial, or you think it does not have much evidence or at least consistent impact on the risk of dementia?
Yeah, so I think it's a really interesting question. What we need to investigate, and to some extent that's been done, but it's very difficult to disentangle. Because we see in what study I did, where we saw the benefits, the short-term benefits, they were seen in women who were highly symptomatic. And the question is, if you do it at that time to reduce the flushes, because HT is very effective in doing that, do we then reduce the later life risk for dementia? Now, the ELITE and KEEPS didn't show any increased or decreased risk with giving treatment or around the age of menopause. However, my cognitive tests were used. Some of my cognitive tests, like a visual sensitivity test, which is really sensitive to early dementia, was used in that study. And when we got the data back, the statistician didn't want to analyze them because it was a multi-center trial, and some of the data were really, really messy, indicating that some of the centers hadn't really done very well at collecting the data reliably, I think. So something had gone wrong with our test. And this is always a risk with multi-center trials, is that you don't see an effect because of the way that cognitive testing, as you know, is really difficult to do it right. And part of what you're doing when you're cognitive testing is looking at how people are doing it, and then changing your attitude. So if you have a tester who doesn't understand that, we can see different results. Sorry, Chris, you had a question as well.
There is another question posted is, do you
Yes.
think that cerebrovascular risk factors and are important for women for the risk of dementia during their lifespan?
Absolutely. And there's lots of studies actually suggesting that these factors are more important for women than for men. But it might be that the survivor bias plays a role there, and that women just die early, that men die earlier of cardiovascular disease. So they can't be part of these statistics anymore. You can't develop dementia if you've passed away because of the same risk factors. So that is something that needs to be studied, because there's lots of data, including, I remember some of the talks here, suggesting that in women, often cardiovascular disease not really well recognized. It's not treated aggressively. Women are less likely to be given statins. And the other problem that we're seeing is that women stop exercising. A lot of women stop exercising after they reach teenage years. It's not very attractive to be sweaty, so women stop exercising altogether. And in worldwide, only a third of women actually are active enough to reduce dementia risk. And we've seen we don't need to do a lot, but yeah, it's massive. I can see a question about gender differences and smoking.
Yeah.
So in the past, and this is a really good question, because in the past we saw these gender differences in most cohorts. Women had a high risk. But in some of the cohorts, like the Framingham study, we don't see the difference in dementia risk anymore. And that is possibly because more women in the later cohorts, like the later data from the Framingham heart study, um, had taken up smoking, drinking, and a lot of women aren't as active anymore. In the past, if I look at my grandmother, she was washing and walking to the shops and carrying babies around, and she was a very, very active woman, and she died at a ripe old age of 89 without dementia. So lifestyle is very important. And I think it's really important, especially for young women, to be encouraged to take up physical exercise. And we're working with that. In fact, today, after this, I have to rush back to the university to start giving a karate class and a hip hop class. And, we're trying all sorts of things to mitigate, future mental health problems, and also to improve their moods, because we now know in the UK that the worst mental health is actually seen in young women. So I think it takes a lifelong approach with a big, big focus on women. And we now see that in
I,
gender stratified analysis. Yeah.
I have a question. Is when you talk about the HRT and you mentioned that at the later, more recently, people who are more conscious or want to take the HRT are those
Yes.
health conscious women who are
Yes.
who are more educated, lifestyle maybe more
Yeah.
healthy, and perhaps they take HRT being healthy and fit and have an aspiration to remain young for a long period of time. It is at
Exactly.
least some of my encounters with my good friends, and they took HRT continuously
Yeah.
after for a long time after the menopause, uh,
Yes.
because they want to keep everything okay, anti-aging properties from their beliefs.
Yes.
But from the evidence that long-term HRT is actually not definitely beneficial, at least the evidence does
No.
not suggest that
No.
it lowered the risk of dementia. As a public health message to this group
Mm.
of active, healthy, highly educated women, what do you think should be the important message about HRT when
I
they
think it's a
cross
discussion.
65 years old?
Yeah, I think it's a discussion to be had uh, with your GP or your consultant who's prescribing this. I think, and I've been to many, many conferences, on this topic and spoken about this. I think as a woman is healthy and happy, there's absolutely no reason to stop taking it. I mean, the increased risk in the cancers is again like the risk with dementia is only 1% more. So it's 1 out of 100 women more who might develop this over time, and it's really unclear whether this is actually the case, whether that data isn't biased. So I think if you're happy taking HRT, it also protects bone function, for instance, over time, which of course is a massive issue. There's no reason not to. But I would say on the other end of the equation, I've had a lot of women who came to me saying, Eve, should I take HRT? Davina McCall, this actress, was promoting this and showing very sort of selective data from some groups, basic sciences data, which weren't very well controlled, and promoting use of HRT. And women came to me saying, my mom's got dementia. Do you think I should take it? I really don't want to get dementia. For those women, the message should be, it's not going to protect you unless, and this is a big, big question, unless you had an earlier onset of menopause before the age of 45. You might want to consider that, if anything, for bone health. Because what's really interesting there is a lot of women, when they go through menopause, the highly educated ones, they'll start exercising and they don't want to gain weight and want to stay healthy. But paradoxically, of course, that will affect your bone health. And many studies have shown that if your BMI is under 23, you're really increasing your risk of osteoporosis. And so you don't want to do that. You don't want to get too skinny. And taking estrogens for those women might actually have that benefit, because if you have a fall and you have osteoporosis, that's the end of the story. And that risk is much more likely than dementia risk. So I think if you do have early menopause, that is an important consideration to have, especially if you have a low BMI and you really are at risk. So, but again, these are questions looking at individual risk profiles. I am wary of this increased risk in dementia, but I think that could be explained by that healthy prescription bias, where women were given it because at the time we were convinced it would reduce the risk for dementia and heart disease. So particularly older women, and we could see that increase before the Women's Health Initiative data in many more women, also in the UK, but especially in the US. At one point, more than half of the women, were taking this, maybe even 75% of women were taking HRT. Older women convinced it would protect their health. I think apart from bone health in women who are underweight, I don't think there is any reason. Some women just report they feel better, but a large part of that could be placebo. It might improve your skin. I don't take it, but because I'm aware of the risk, and my mom had breast cancer, but so I'd rather not increase that risk. But certainly vaginal dryness is something to be considered. You could use topical estrogen, very important, and that does not affect the risk of dementia at all. So there are indications, but not to reduce the risk for dementia, and probably not to reduce the risk for heart disease. The NICE data said there wasn't enough evidence for this from the randomized control trials. But I told you about the caveat with those randomized control trials. There were some indications that might protect against some aspects of cardiovascular disease. And the observational studies definitely show reduced risk of cardiovascular disease. But again, it is because of a whole package of lifestyles. These women also exercise more and eat better diets. And I think that has a much bigger effect on reducing dementia risk and heart disease than HRT would.
Thank you very much. And I fully enjoy your talk. And I pass the time back to Krish.
Thank you, Eve. I think that was really lovely scholarly talk. Gave us a lot to think about. And I'm sure that we'll hear more from you in a future talk about what you have decoded. Just wanted to point out that the effects of yoga that you're talking about may also be because of its impact on autonomic function.
Yes. I was just thinking that, and I think we should definitely investigate that, Krish. I'm so grateful. I always come away from these talks with, because they're such brilliant minds, and you're thinking, oh, yes, I hadn't thought about that. But I've been playing around with this. So I think we should look at this and measure this, to see what actually is happening. And again, the importance of good practitioners. Like in our studies where yoga didn't do anything, there wasn't a trained yoga practitioner. And I think, from visiting your wonderful center, if you have somebody who's versed in this, who actually understands it rather than, have some mumbo jumbo around this, but understands the importance of the breath and, the calming of the autonomic nervous system and, the engagement of the core, for instance, these are so crucial to show benefits. And I think that's very important when we're investigating this. And we are now running a study looking at how people practice mindfulness. So whether that effect of, increased risk for poor mental health and poor cognitive function due or not due, but associated with mindfulness could be related to the way that they engage with it. Because I'm convinced that if it's external, you actually benefit. But for many people, if they internalize, and that is the same with yoga, with the breath, and it's not supported by the right practitioners, you actually have a negative effect.
In fact, I would like to point out that Linda is a yoga practitioner and she actually comes to India to do yoga retreats and stuff like that. So
Oh,
I'm sure you both will
fantastic.
find things to talk about
Yeah.
offline.
Yeah.
So thank
Thank
you
you
so
so
much.
much.
You.
Great
Thank you.
webinar. And thank you to everyone who's joined us today. And we look forward to meeting you at our next webinar.
Thank
Yeah.
Thank
you.
you,
Thank you
Eve.
so
Thank
much.
you, Linda.
Thank you.
Bye.
Okay. Speak to you soon. Bye. Take
See you.
care.
Bye.
Thank
Bye.
you for the invite.